Sorry. Good afternoon, everybody. My name is Jose Maimani. I'm a medical oncologist with Rocky Mountain Cancer Center. Today I have Dr. Les Busby, who will be updating us as far as the latest and greatest as far as GI cancers that was presented at our annual meeting, ASCO, in June. Les grew up in Montana. He's been, around the block, so to speak, here in the West. He did his fellowship training at Utah and has been in practice in Boulder for quite some time now. Les used to serve as our chief medical officer at Rocky Mountain Cancer Center. Now he's the chairman of our Pathways Committee, which oversees pathways as far as cancer treatments nationally through U.S. Oncology. Today, he's going to be going over some pivotal trials as far as immunotherapy in colon cancer. So I will go ahead and hand things over to Les, and towards the end, we'll answer some questions. So if you all have questions, go ahead and comment via Facebook, and we'll look through those at the very end. So all yours, Les.
Thank you, Hussein. And you might want to close your eyes when I share the screen here because it gets a little bit weird. All right. So, and we can go ahead and get going here. I thank you again. And then the study I wanted to discuss today that was presented at ASCO is, and during their plenary session, which is considered their top abstracts, was pembrolizumab versus chemotherapy for microsatellite instability high and mismatch repair deficient metastatic colon cancer. This was presented by Dr. Thierry Andre. He's from Paris, France. And this was an international study, both in Europe, United States, Japan, and even China. Before we get into the study, I thought it'd be good just to give a little brief background. Each year, there's about 150,000 colorectal cancers in the United States, and about 53,000 people will die from colorectal cancer each year. In a certain group of colorectal cancers, there is an abnormality in what's called DNA mismatch repair. So when a cell tries to divide into two cells, it needs to duplicate its DNA. And when it does this, sometimes there are mistakes where the wrong group is put in to the DNA. And somewhat illustrated on this cartoon, the GT, that actually should be an AT, and you get these little bubbles, for lack of a better way to put it. And these enzymes come through here, identify the bubbles, and repair them. If that mechanism is inhibited, then errors can continue on through the lifespan and subsequent divisions, and these could lead to problems in DNA that can cause malignancy. About 3% of all colon cancers, this abnormality is inherited in something called Lynch syndrome, and about 15% of colorectal cancers, it just happens spontaneously in the cancer itself. Pembrolizumab is a drug that's called a PD-1 inhibitor. It's part of the immuno-oncology. We know that your body is protected from your own immune system because it can be pretty powerful, and it's through these mechanisms called checkpoints. Some cancers hide behind these checkpoints, and drugs such as pembrolizumab can open that up and allow your own immune system to attack. There's been some studies in colon cancer, and this upper graph, the red is in people who that mismatch repair was working, and the blue was colon cancer in which the mismatch repair was not working. And this is how much change there was in the tumor markers as well as down here below the tumor size. And if I can bring your attention to the other side here, when you look at the response rate, that is how well it shrunk the cancer, those with mismatch repair problems, about 40% of the cancer shrunk, where in those that this was intact, really nobody responded. So this led to the drug being approved for people who'd had previous chemotherapy. This study was to take patients who had not had any previous chemotherapy, and they randomized into two groups. The first group wasn't just pembrolizumab alone, and they continued on until either they developed toxicity, progression, or for a total of 35 cycles. Each cycle is every 3 weeks. The other group was randomized into standard chemotherapy. If they progressed or had to stop for other reasons, they had the option as part of the study of crossing over or using the pembrolizumab, and a certain percentage of the group did do this. I also want to point out that they assessed the tumor at about 9 weeks and then every 9 weeks afterwards. Just briefly on the chemotherapy, I highlighted these two regimens. These are combinations of drugs, but the most important is these two regimens I would consider the two most common regimens used in the United States as well. So basically 70% of the patients got a regimen that's used very commonly. And then the other regimens are also, while less commonly used, considered reasonable depending on the certain circumstance. So if we look at how well these patients did, if we look at the response rate, pembrolizumab, the response rate was just over 40% versus chemotherapy at 33%. P-value is a statistical calculation where basically anything less than 0.05 is thought to be more likely to be real rather than just due to chance at all. So it was felt that the pembrolizumab arm was slightly better in shrinking the cancer. One other interesting item was this section called progressive disease. The pembrolizumab arm was at 30% versus 12%. What this means is at that first CT scan at 9 weeks, 29% of the people getting pembrolizumab were having cancer that was growing versus only 12% of chemotherapy. Reason that's interesting is in this graph, what we call progression-free survival. That is how many people were alive and receiving treatment and the cancer wasn't growing. This green graph is actually the pembrolizumab arm. So there's a pretty rapid drop off early on, but then you see a very prolonged time period where people are on the drug and the cancer was not progressing very rapidly compared to the chemotherapy arm in red here. At 1 year, over half of the patients on pembrolizumab were still on the drug and doing well. We're just over a third of chemotherapy, and that carried pretty well to the 2-year, where just under half of pembrolizumab versus just a fifth. Another way of looking at it is those patients who responded in that first 9 weeks, that is, the cancer shrunk, those who were on pembrolizumab, they maintained that response for a very long time. And when we talk about median duration of response, it is how long did half the patients continue to respond. It still hasn't been reached almost 4 years out. Importantly with the treatment is, well, how well did the patients tolerate it? And I want to highlight grade 3 toxicities. These are toxicities that are very severe, often lead to hospitalizations. And you can see with the pembrolizumab that they were about a third of the toxicity compared to chemotherapy, especially the severest. Toxicities in pembrolizumab typically are what are called immune mediated. That is, the immune system is now attacking healthy tissue rather than just the cancer alone. But for the vast majority of patients, they were relatively mild with only just a few what we consider grade 3 or the most severe. One comment on the crossover, that is those patients who were on chemotherapy, progressed on chemotherapy, and then were offered to cross over to the other arm. Just over a third of the patients took advantage of that, but another 35 patients ended up getting a similar drug to pembrolizumab, but off study. So a total of 59 patients who got chemotherapy ended up getting this class of drugs like pembrolizumab. It's too early to tell on overall survival and whether or not people do better getting a drug like pembrolizumab first and then chemotherapy, or the opposite. We're hoping that this will come out here in the next year. So if I can conclude, pembrolizumab, when compared to standard chemotherapy regimens, improved progression-free survival in those patients with frontline, that is, not received therapy, metastatic, mismatch repair, or microsatellite instability high colorectal cancer. The median progression-free survival was 16 months versus 8 months, or a doubling in the time period that the patients had to change. And as we said before, the 12-month and 24 months were nearly 50% versus continuing to drop off with the chemotherapy. Pembrolizumab also had fewer serious side effects. And it is interesting, upfront progression was higher with pembrolizumab, but those that responded made up with it over time. And the final conclusion is all patients with metastatic colorectal cancer should be tested for this. We'd recommend testing on the tumor first, because far more of the tumors itself will carry these abnormalities than those people have a family history. Now I'm available to take any questions.
All right, Les, thank you for that that summary. That story of MSI high and MSI tumors with PD-1 inhibitors has been ongoing for a few years now. So it's nice that it finally came to fruition and was presented. As far as therapies in the future, do you ever foresee this being incorporated in the adjuvant setting? I know this is a small patient population, and to add to its complexity, a lot of these patients, if they're stage 2, don't necessarily need chemo after surgery, but for higher stage tumors, do you foresee us incorporating a combination as a clinical trial in the future of doing FOLFOX plus Keytruda?
Yeah, I think that is the absolute next question to look at. As you stated, that anybody that has a cancer spread to lymph nodes, we pretty much recommend chemotherapy. But there's a lot of discussion on those stage 2. Some people get benefit, some seem to not. Interestingly, the people that might not get as much benefit from the chemotherapy are actually this group. They tend not to respond as well. Right. So I think it might open up an opportunity. The cure rate from surgery alone in a stage 2 ranges somewhere between 70 and 80%. So most people are cured with surgery, but those that quarter of other patients, this would be potentially a great opportunity. But as you know, right now, we just don't know. And it'll take a little time because most patients do well. Right.
Yeah, it's going to be hard to get that patient population, stage 2 or 3, and put them in a randomized study. But it's good that at least this story's been told. So we don't have any questions about colon cancer just yet. We do have 2 questions. One from Denise about any updates as far as pancreatic cancer, and as well as Gina. I didn't really hear much as far as pancreatic cancer this year from ASCO. There wasn't really much in the way of new lines of therapy. I think the PARP inhibitor story was well told a year ago, so I hadn't heard anything. I don't know if you had.
So yeah, still very challenging cancer. I think the biggest things I've heard lately is people that have potentially resectable or borderline resectable, looking at doing some chemotherapy or treatment up front before going to surgery seems to be more and more of a benefit. And that's something we've discussed for a while, but we're seeing that those studies confirming that as well.
Right. Yeah, and I think there's going to be an update at one of the national meetings about using liposomal irinotecan with oxaliplatin 5-FU, so FOLFIRINOX, but instead of the ERI, use liposomal irinotecan. I don't know as far as efficacy if that's really going to be a groundbreaking study, but I haven't heard much from ASCO, at least, from last month as far as pancreatic cancer. So
yeah, and very rare to kind of tie it into what we talked about here. Pancreatic cancer, on average, just doesn't respond very well to immunotherapy.
Right.
There is a tiny number that might have these mutations, and it does seem like there's some of them can respond. And then back on colon cancer, one of the two issues that I saw discussed in relationship to this study was, one, could adding this to chemotherapy help improve? And that's an unknown question. But two, can we figure out who those 30% are up front that don't respond? And either can we add something to it to help them respond, or can we offer them something else and just walk away from this treatment? And that's still to be determined.
Right. And Denise had mentioned that she's a 2-year survivor after a Whipple, which is fantastic.
Yeah.
So congratulations on that, Denise. It's pancreatic cancer is hard, but that also, this story of MSI status is also really important as far as path goes, right? Yeah. So when it comes to something like pancreatic cancer, the more path we have, the better. We're able to send next generation sequencing, send for different mutations. For example, KRAS is something that we're looking at as far as targeted therapy. So tissue is always vital in oncology, and more so now with all the different types of testing that we can do. So,
yeah, and I think one of the things I still think we're a few years away, but that's getting really exciting more and more is this what's called liquid biopsy. We're being able to maybe identify the cancer just by a blood draw. A recent article published that we participated in that study that shows that it is a viable option to go forward with. And then the best part is if we can identify, because pancreatic cancer is a great example. Early on, sometimes you're dealing with tiny amounts of pathology. So if we can find a better way to get those answers, something that I've been hoping for a long time.
Looks like we have another question about hepatocellular carcinoma, an area that perhaps, a year or 2 years ago, was a disease that we didn't have too much to offer, but really has changed dramatically within the last year. Les, I didn't hear much from HCC this year. I know there have been a few articles published about using immunotherapy up front for patients that have HCC, but at least from ASCO, I didn't hear too much as far as updates. And of course, the combination of nivolumab and ipilimumab, which appears to be popping up everywhere with every tumor type, got FDA approval, I believe, a few months ago.
Yeah, I think, several years ago, we had really nothing. Sorafenib, which had just very mild activity, and then lenvatinib, I think a little better tolerated. Immunotherapy looks very interesting. And as we've seen in our kidney cancer, my guess is mixing something like sorafenib or lenvatinib with an immunotherapy might might have interesting activity. Haven't heard anything new yet, but definitely slowly chipping away on a difficult cancer to treat in the past.
Right. Yeah. It seems like all the makers of all the immunotherapies they're all making a lot of progress in HCC, and a small percentage of them, it's not the majority, but a small percentage of them appear to be responding to immunotherapy. So that's promising. It's just the rest, the majority that really need more help besides just TKIs, which, work well, but only for a short period of time.
Yeah. And as I said before, sorafenib, some people can really have a hard time tolerating it. So it's also a challenge to manage.
Right. Thank you for your question, Wendy. Any other questions for Dr. Busby? All right. Well, I don't think we have too many other questions. I think we're going to go ahead and wrap things up. I really want to thank everyone who joined and everyone that's going to be watching this later today. This is the first time I think that we've done this via Facebook, taking research from practice, and these are things that us doctors are talking about on a daily basis and really presenting it to the patients. So this is the first time we've done this. So if you all have any suggestions as far as what you'd like to see us do differently, we'd be happy to hear from you guys. We plan on doing more of these sessions in the future. So thanks to everyone that's joined. And Les, thanks for doing this. I really appreciate it. I know you're a busy man. So thanks for going through this with the patients, so they all genuinely appreciate it. So
I appreciate it. It's fun. And I like getting this information out to the patients. So
okay. All right. Thanks, everybody.